Thank you all so much for coming tonight. I'm so excited that you're here. My name is Joy Brown-Kirst. I am the founder of Modern Age Skin. It's a skincare line specifically that I created for women in perimenopause and menopause. So this is super exciting to me that you guys are here. I know a lot of you have since a lot of my friends that are here that have been in Bronxville this whole time have kind of followed me through this whole process. But I started this quite some time ago when I was just fiddling around in my kitchen trying to fix my own problems, basically. I had skin issues. All of a sudden, I'm in my late 30s to early 40s, and my skin started to break out again, just like I was 16. It was really dreadful to have to go through that again. So unbeknownst to me at the time, that was really just one small problem that wasn't just my skin. It really was my whole body. And, Heather will be talking a lot about this, but it really made me feel terrible. I felt like a teenager and I didn't want to show myself. And I did a lot of public speaking then too. So it was really difficult. But once Modern Age Skin really became a reality, I knew for me, once I learned that was not just skincare issues, it was really a whole body issue, and it was perimenopause, that I knew that one of the pillars of this business really needed to be education so that people could know and talk about these things like we are now. It's been 15 years for me since that started. And just now is when this stuff is really beginning to become important. So I'm very excited that you're here. And since education is one of the pillars, I am super excited to be with these amazing women that are here to talk with us and help us make this an open conversation about perimenopause and menopause. So we're going to talk a lot. They'll each answer some questions. And then at the end, you guys can ask questions, as many questions as you like. And I know that they're all amazing with answering these kinds of questions. So I'm going to introduce you guys first. My first guest here is Dr. Heather Hirsch. And just to be transparent, she is my doctor as well. So and I can attest to the fact that she is tremendous and has helped me so much. It's been really, really great. So she's a board-certified internist, nationally recognized menopause expert who founded the Heather Hirsch Collaborative to provide accessible, evidence-based care and education for the millions of women navigating midlife and menopause. Anita Merchandani is a registered dietitian and fitness professional with over 17 years of experience in women's health and the founder of ARM Nutrition, a nationwide telehealth platform making expert insurance-covered nutritional care more accessible than ever. And finally, Claudia Flynn. She's a licensed esthetician and founder of Skin Confident Spa and Om Skincare, specializing in acne-safe, anti-aging treatments with a focus on hormonal skin changes and advanced skincare techniques. So we thought the best way to start this was let Dr. Hirsch talk a little bit about perimenopause and menopause 101 and give you guys kind of the basics so we're all kind of starting in the same place. So
I'll take it away, even though that could take me several hours. So, gosh, there's so much that happens to us as we go through, I was going to say perimenopause and menopause, but if you think all the way back to like your first period and then, maybe becoming sexually active or trying to get pregnant or trying not to get pregnant and then getting pregnant and then having a miscarriage and then breastfeeding and then another one and then another one or not. And then you're like, I can finally relax now. No. Because then we enter perimenopause and menopause. And my job is to actually make them not so scary, even though we hear a lot about the negative things that can happen to us, from the brain fog and your hair falling out and your skin changing. But really, knowledge is power. And I appreciate that, Joy, so much that education had to be a part of this, because not only do we want to help to solve the problem, but we want to make you understand what's happening to your body and that you're not alone. All right, well, let's start with the basics. So menopause is defined as a year of no periods. So if it's been 12 months, it's menopause. And menopause lasts one day. And then every day after that, you're actually postmenopausal. And you think about menopause, and many of us may think about that's like for my mom, or that's for my grandmother, or we thought that if we're already there. But these things happen actually before our very eyes. Time is an interesting thing. It goes slow, but fast at the same time. So menopause has been 12 months, no period, and then you enter into postmenopausal state. And in the postmenopausal state, we should talk about what our hormones are doing, because we're going to talk about that in terms of our skin and our body composition. So your estrogen, which is made in your ovaries, kind of starts to slowly go down and then really kind of peters out postmenopausally. And same with progesterone. Kind of same with the testosterone. So if we go backwards from that, perimenopause is the years leading up to menopause. And the thing about perimenopause is it's basically menopause, but you're still having periods or you're still ovulating. If you're a woman who doesn't get periods because you've had an ablation or a hysterectomy or an IUD or something like that, you're still menstruating or you're still ovulating, but you're having these symptoms, but you're not yet menopausal. So this makes you feel like you're going crazy at the same time because you don't understand why these things are happening to you. Acne out of nowhere, or breast tenderness out of nowhere, or mood symptoms that don't feel like yourself. That can be a lot of the journey, but really can start in perimenopause. So we know that that can last even 10 years before your last menstrual period or before that one day that is menopause. So those are kind of the main definitions of things that happen to us. And the mission tonight is to really demystify, debunk a lot of this, and help you, especially if there's certain places where you want more information, whether it's skin or it's your body composition, it's weight changes, or these other symptoms. We're really excited to talk about all of these things tonight.
Talk about what's people, you get this all the time. I'm sure some of you have maybe gone to your doctors and they're like, oh, you're too young, right? You're too young for that. So what's too young? What's that span look like? What's normal? Which I hate to use that word in this, but it happens all the time.
Yes.
So
this is a great question. And, I'm excited because I actually have a book coming out this fall called The Perimenopause Survival Guide, because perimenopause is, if you think menopause is confusing, perimenopause is even more confusing. But perimenopause, per the CDC, the average age is 47. Although if you ask me, I see patients and women all the time, and I think it starts much earlier. I think a lot of women have symptoms in their late 30s, early 40s, but we haven't really put the pieces together because everyone's kind of telling us, well, you're just stressed. You're not sleeping. You're worried about this. You're worried about that. So your sleep is bad. And so that's why you're stressed. And so that's why you're gaining weight. And that's why your skin's changing. And you're not hydrating enough. And you're not meditating enough. And you're not doing all these things. So we know that the body starts to change physiologically for many women in their 40s, but for some women in their 30s. And this is natural perimenopause or natural menopause, but many women will have earlier surgical menopause or earlier menopause, so it can always happen earlier. So the first things that we might see if we're starting to actually put these pieces together to see if what we're experiencing is perimenopause would be maybe a change in your cycle. So periods that are either lighter, shorter, heavier, anything, different color. You can tell me anything. I've heard it all. And that can be one of the very first signs. The other things that we'll see is actually in perimenopause, the progesterone will start to decline before actually the estrogen. And we're going to be talking about our little sex hormone friends, estrogen, progesterone, and testosterone tonight. So as progesterone declines, progesterone is kind of our natural relaxing hormone. And so anxiety can spike. Anyone have an increase in anxiety in perimenopause?
I did.
Oh my gosh, I did. Yeah. And insomnia. And that could be many things. Nothing is siloed. Perimenopause can't be blamed for everything. But there is a change in these hormones which affect our brains. It affects our central nervous system. And progesterone, which declines first in perimenopause, is kind of our calming hormone. So we can see anxiety spike or ruminating thoughts spike or insomnia spike. I know. Great. I got more for you. And then as estrogen starts to change, estrogen will both decline but also spike. And so this is where we can get some symptoms like breast tenderness out of nowhere that makes you also feel like you're 16 again. Or acne, as your estrogen and progesterone and testosterone are all over the place. We're going to talk a lot about that. You can also have strange symptoms like fatigue or brain fog that literally make you feel like you're going crazy. I do a lot of social media, and I've been starting to get the brain fog as well. And I'll sit in front of my camera, something I've been doing for years, and I'm like, and I don't know what to say. And so the blooper reels are great that my team has. But that brain fog, and it just doesn't feel like you feel stuck, and that can affect your productivity at work, that can affect your self-esteem. Changes like vaginal dryness or painful intercourse or a change in even libido, things that, are a little taboo to still talk about, probably even with your friends. These are all normal things that can happen as these hormones are declining. And so because perimenopause seems so separate or so distant from menopause, and no one's really been talking about it, and doctors are not good at diagnosing it, you can just feel like everything is spiraling and you're not sure what to point to. So hopefully after tonight, you can sort of start to think about, how can I put all these pieces together? Well, I always encourage people to start tracking and journaling. And if you start kind of tracking what your periods are doing, or how your mood is, how your sleep is, your libido, if you're having any of these other symptoms that we've talked about, could be acne, could be joint aches and pains. It literally could be anything, I know. You can blame it on that, but start tracking, because if there is any type of cyclic pattern, you might be able to loop that back to perimenopause. And the good news is there's actually a lot that we can do.
Thanks for that.
Everyone's like, we did a lot.
What I can say though is that knowing, I mean, not to sound like a cartoon from the 70s, but knowing is half the battle, really. I mean, you feel like so much better once you know some of these things, that you're not crazy.
Yes.
Right? And that's kind of the way you feel for such a long time, that you're just crazy and you think it's all in your head, or all the various things that we like to point at as women to blame ourselves for things. But
yeah. And you can worry about a lot of different things. Do I have dementia? Am I getting early Alzheimer's, right? Because we're all thinking about brain health, and we all have the brain fog. And so all of a sudden we're booking the neurology appointments and getting MRIs of our brains. And so it's nice to know that these things can be expected. And even something like brain fog, research has shown that it actually can get better, even if left alone. And so it's nice to know what these symptoms are, so that you can maybe attribute them to things, because common things happen commonly. And it's most likely that if you're in this room, you have or you are experiencing perimenopause, or you will, one of those three. And so it's nice to know that maybe it's not doomsday. It's just this season in life. And that's why knowledge is half the battle. Yeah, totally.
So Anita and Claudia, what have you seen, like some of those changes in estrogen and the systemic effects of the estrogen? What are some of the early signs that you see kind of in the body, or nutritionally, or in the skin, that kind of make you go, oh, maybe you should think about that a little bit?
Sure. So for me as a dietitian, I think the biggest red flag that I get from people from women, is, so I don't know, all of a sudden I feel like I've gained weight. I feel like I have like this tire, like this belly. I'm not doing anything different. It didn't come from anywhere. I know I didn't eat any more than I used to. I mean, I don't even drink wine anymore. I barely even eat chocolate. I'm like, okay, hold on. And everyone starts spiraling, because I really hate this, because as a dietitian, I'm super, like, I have a really balanced and it's a marathon, not a sprint approach. And I think that people start thinking that they have to go into this this restrictive mode or restriction. And so usually it's abdominal adiposity. Sometimes it's hair loss. I do get a lot of skin related rashes and or random allergic reactions. All of a sudden people come to me and are like, I think I'm allergic to peanuts. And I'm like, huh. And they're like, because in the last 3 times I've eaten peanuts. And then so it's like, let's be detective. And I work with them to investigate, how did you eat your peanuts? What time did you eat your peanuts? Was it peanut butter? Was it raw? Was it salted? It's crazy, all the questions that you can start asking to uncover what exactly is happening. But I would say that those are probably the most common. And of course, fatigue. It's a lot of exhaustion, especially when people wake up in the morning, when women wake up in the morning and the hustle is real. And all of a sudden they're like, I don't know, I don't have energy. I wake up and by 9 something, I'm drained. Or I'm by 10 something, I'm on my 3rd cup of coffee. And it's like, okay, let's dial it back and let's figure out, why are you not waking up with good energy? What's causing you to slow down? How can we fix this? So it's a lot of these, I seriously sometimes think I should be a detective, because I take every case like a case study and try to uncover, because no 2 people are alike. Nutrition is very individualized, and the approach for someone is not necessarily the approach for someone else. Though there are some overarching lifestyle modifications that are probably great for everyone, but it's how you sort of put that into practice that, we see, as Heather said, there's a solution for everything. So that's what I see physically.
And what we know, especially facial skin is very different from the rest of the skin on your body. So
yes, for a lot of my clients that come in for the first time, I get a lot of, I feel old, I look old, I feel like crap, my skin is dull and dry and gross, and I don't know what's happening, and I've acne. So especially that's quite daunting for people who've never had acne as a teenager either. I'm trying not to get too scientific with this because I will go on for days. But dryness, dehydration, it's all linked back to a decline in androgens in the body. Estrogen affects the dermal layers of the skin. So that's where we see the sagging, especially around the neck and the jowl area. Yeah, there's a lot that goes on in the skin, and there's a lot that the hormones play a massive role in the formation of the actual skin cell as well. So, once you deep dive into it, it makes sense when you look at the role that the hormones play and how you wake up one day and you're like, oh my God, what's happening? I need to book a facial. But the good news is that it can be fixed without super expensive, treatments or cosmetic surgery as well. So there's hope. It's not all negative.
So, well, sticking with that then what are some of the treatments that you recommend most for women kind of in this middle age? So this kind of stuff is starting to happen. What do you recommend to them?
Home care is where it's at. It's going and getting, a skin consultation with somebody who knows about hormonal skin. And it is, really looking at what your symptoms are. 90% of the time it's dryness, it's dehydration. So coming up with a 5-step routine, nice cleanser, super hydrating serum, looking at the ingredients, it doesn't have to be brand specific, but looking at the ingredients that are in your skincare, hyaluronic acid, beta glucan, allantoin, they're going to be in every hydrator. Every single person, regardless of what their skin condition is, should have a hydrator in their routine. So that goes on after you cleanse, when your skin is still damp. Using a moisturizer that has capillary supporting ingredients in it, like copper peptides, vitamin K, supporting, nourishing, calming ingredients. Joy, you can speak about your oil as well, which I think is really relevant.
Yeah, so when I set out, I am the formulator as well, for those of you who don't know me. So when I set out to create the brand, I always think about soothing, calming, clearing type of ingredients. So antibacterial, anti-redness, those types of things. Your skin will naturally, it gets thinner as the estrogen decreases, your collagen production decreases, in which case then your skin gets thinner. So it can get more irritated. You can get all of a sudden, we're never sensitive to anything, and all of a sudden you are. It's not unusual. It does happen to a lot of people. I was never sensitive to pretty much anything, and now I am. So I'm very, very careful about what I put on my skin, and what I tell all of my clients is be kind to your skin. Don't scrub. You're going to leave little fissures in your skin. Use something that is gentle. I have in one of these products, I have a buffered lactic and glycolic acid, so it doesn't sting when you put it on. It's time released over the course of the day and into the evening. So it's not going to be super aggressive. You probably won't even see any peeling. And those kinds of things are what I always recommend people use. Find things that are nourishing and skin barrier repairing as well. And a lot of these things will not go away, but it will look much better.
Yeah,
skin will feel better.
Skin barrier health is the optimal goal, no matter what the condition is. If it's a teenager with acne, or if it's somebody with really bad, symptoms of menopausal skin. A healthy skin barrier is hydrated. It is nourished. It is calming. It doesn't react to products that you've used all your life, and then you wake up and you're like, oh my gosh, I can't use this anymore. Not dry, not red, not irritated, not flaky. Again, with the formation of the skin cells, when we have the decline in hormones and in calcium as well, what happens is that the skin, the outer layer, which is the epidermis, and where the skin barrier, its whole function is to protect us from outside elements, it can't perform correctly without those hormones and without the calcium. So you have things like natural moisturizing factors. The skin can't moisturize itself, and it can't retain hydration. So that's why it's really important, twice a day, morning and night, to be doing your routine, and to steer clear, in my opinion, of super harsh, severe treatments. Even retinol, like tretinoin, love it, but once every 2 weeks. Because when the skin is naturally thinning due to the decline in estrogen, vitamin A, especially strong forms of it, it's going to continue to thin out the skin. So I see a lot of people who've used tretinoin all their life, and their forehead skin is really thin, And that's from the decline in hormones as well as those strong products. And then as regards treatments, the one thing that I would avoid, anything that heats up the flesh or the tissue under the skin can actually break down the fat in the skin, and we need fat in our face. It contours, it shapes. So things like radiofrequency or very high level lasers that actually heat up the skin is going to dissolve the fat, which is fine from the neck down, not so hot from the neck up.
Yeah, true. And anything else other than tretinoin? I mean, I avoid retinol myself. I don't react well to it. It dries me out so badly. It's terrible. It makes it itchy. It's not good. Anything else that you would recommend?
To use or to stay clear
to stay away, or to really seriously think about it before you use it. Everybody's different, obviously.
Yeah, so it all depends on your skin type, your skin, whether you're dry, whether you're oily, whatever it is. But I always tell clients, it's up to you. You need to know, when you wake up in the morning, is your skin dry? Okay, pull back on the active ingredients that you're using, be that retinol, even some vitamin C's when you use them day in, day out can be quite drying. So look in the mirror and analyze your own skin. If it's dry, I need more hydration. If it's oily, you probably actually need more hydration too, because your skin will try and compensate by producing more oil when it's lacking in hydration, which is water, with your hydrating serums, your hyaluronic acid, all of that kind of thing. Don't love scrubs ever. I definitely come from a more progressive and consistent philosophy than a severe, deep, intensive treatments. I like little and often, as opposed to doing something super expensive and super, deep, severe, I can't think of the word right now, that's going to cause inflammation in the skin. So, and collagen inducing therapies as well is what you want to be doing. So be that like micro channeling, micro needling on a small needle. I don't like those really deep treatments. Electrical muscle stimulation, anything that like lifts and tones and tightens the skin, even things that you can do at home as well. But personally, I'd steer clear of anything, as I say, like radiofrequency that heats up the dermal tissue, because you don't want to destroy the fat in the face or push your skin back into an impaired barrier state.
Okay, thank you. And so can we move on a little bit to nutrition, that hormone? You sort of touched on it a little bit about what people come to you saying. Why does that weight distribution really change during this phase, and what's really going on with our metabolism?
So primarily because of the hormonal fluctuations between estrogen and progesterone, we tend to start seeing a decline in muscle mass. It happens, and you can't control where you're losing muscle. And so things naturally become flabby. But the abdominal adiposity is usually related not necessarily to, yes, everyone might be stressed, you might be hustling, but there is an inflammatory response that's happening in the body. And the abdominal adiposity is kind of in front of the adrenal glands. And the adrenal glands are what secrete cortisol. And cortisol is an inflammatory hormone. So if you're seeing that, chances are, probably if you were to, get your blood drawn, you might see normal levels of cortisol many of the times. But it's more of the fact that when you are possibly stressed, or there is, an exertion beyond norm, or there's a period of time where your thoughts are on overdrive, your adrenals are like over pumping cortisol and then coming back, and then pumping and then coming back. And so that constant, it's like push, 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 come back. It's going to tire them out. And so one of the natural responses from that is, the abdominal adiposity that we see. That's one aspect of it. We tend to see, I would say that our metabolism over time feels like it's slowing down because, number one, correct me if I'm wrong, but I would say that most people have changes in movement. Sometimes we go through periods of time where maybe we're not moving as much, and because life is so busy, because we're focused on working, managing families, managing social expectations, things like that. And what happens really is that we're eating, which is calories in, and our output, which is exercise, calories out, that deficit shortens. So it's not necessarily that you're basically not in a pattern of where there's a deficit of calories, which leads to weight loss. Not necessarily weight gain, just more of like stagnant. And so I see that a lot with people when they tell me their routine. Sometimes people are like, but I'm not eating anything bad. Like I'm eating a salad with chicken for lunch, and I'm eating, a protein plus a starch plus a, vegetable for dinner. And then, there's more nuances than just that we kind of like talk through. But the metabolism, I think the biggest thing to notice is that we just have to make sure that we're finding, and this takes time, but it's a formula. Every one of us has a unique formula that we have to figure out what it is that we're supposed to eat, when we're supposed to eat it, how we're supposed to eat it, how it's paired. It's more than just, let me tell you to eat a salad for lunch and let me tell you to eat a protein, starch, and vegetable for dinner. You're going to look at me like I'm crazy because you're going to tell me you already do it and you're not seeing results. So it's kind of like more individualized, I guess I could say.
So I know you mentioned earlier too that there are certain things that everybody could do that would be really helpful. Is there any sort of nutritional, certain foods or like anything that we could be supportive for everybody that's going through this?
So more than specific foods, I like to talk about your day-to-day lifestyle. So I'm a big proponent of eating dinner early. Like early bird special, my friends make fun of me. They're like, wait, what, 5:30? And I'm like, trust me on this, you'll sleep so well. And they look at me like I'm absurd because we're like, we don't even stop. no, we have calls till like 6. We have to get the kids, make sure the kids are okay. Most people don't have, help, or like their caretaking is, unique to certain hours. And so they're like, I have to hire a babysitter and like, I can't get up before 7:30. And I'm like, 7:30, my lights are off in my kitchen by like 6:45. Like that's absurd. So I think that if you can work towards, and I call this the 80-20 rule. So 80% of the time you are strict and you find a way. When I say strict, I mean you find the best routine that works for you to feel great 80% of the time. 5 days out of the week, out of a 7-day week, and 2 days you live your life. You socialize, you go out, you have a late dinner, you have a couple of drinks. It's book club night and you want to go crazy and have some peanut M&Ms, whatever. So you do that. But that's kind of like the overarching balance I try to help people understand. And within that, eating dinner early has such crazy, amazing benefits. So if you can do that 1 day a week, 2 days a week, start baby steps and see how that works for you. The longer, so it's basically like following a circadian rhythm. You stop eating anywhere between 5:45 and 7:30. You don't eat breakfast the next morning, and you should eat breakfast. It doesn't have to be first thing in the morning. Somewhere around 9:30-ish. That's about 14 hours between your last meal and your first meal. So this is not intermittent fasting. This is circadian rhythm fasting. It's called giving your body digestive rest. The reason your bodies need digestive rest is because your organs have to have time to do what they have to do. So if they're too busy focusing on digesting and metabolizing and absorbing food, they slow down. They're like, girls, ladies, can you give me a break, please? It's like you go to work and you clock out at 5:30 and your boss calls you at 8 and is like, hey, I got a proposal. We got to crush it. You think you could just put in 2 hours? It's like you saying, hey, small intestine, I'm going to have some, some dinner now and then a couple of drinks, and I got to have my chocolate cake too. So you think you can just digest it, metabolize it, absorb it, send it where it needs to go and put me to bed on time and then wake me up with energy? No, it just doesn't happen. So I'm just giving you the science behind it. But that's kind of like one of the biggest things I talk through with people is to figure out what is the optimal lifestyle, schedule to eat, that whole timeline, and how can you do it consistently for longevity.
So I love that circadian rhythm eating.
Yeah.
Yeah. I've never heard of that before, but it's amazing.
Oh, yeah.
HRT.
Yeah.
Everyone needs to know about it. There are 8,000 different stories out there of what you should and shouldn't do and what works best for everybody and all of those. But
Yeah.
I'm going to leave it to you because you're the expert.
Yeah. It's such a big topic. So again, I know we've all had big questions to answer in a little bit of time. But when it comes to hormone therapy, one of the first things to think about is the fact that we've I guess, demystified. Debunked sounds like the science used to be bad. It's not that it used to be bad. It's just that we didn't interpret it correctly. So the good news now, and hopefully you've heard on some social media channel or somewhere in your Instagram feed or from one of your friends, that hormone therapy is not as dangerous as it used to be considered. And that really is the truth. So the good news is that hormone therapy is extremely safe, extremely effective. I've been prescribing it for, I think, 14 years. And honestly, all my patients have done amazing. So much, when I consider the fact that patients have landed in the emergency room from aspirin or antibiotics or insulin, which has literally caused all sorts of things, hormone therapy is actually a very safe medication. That's generalizing it for sure. We can talk about some of the big fears if you want during the question and answer session. But to kind of keep things moving along, that first point is that, is hormone therapy really safe? Like really, really safe? Really, it's really very safe. One of the ways in which I think this is helpful to contextualize is that I consider birth control pills to be hormone therapy. Many people have in some way, shape, or form maybe been on contraception. We know that doctors are, maybe you have kids that are on contraception, etc. And that's not considered unsafe, but it's actually really a very similar form of what postmenopausal hormone therapy is. Actually, postmenopausal hormone therapy is actually delivered transdermally and in lower doses, so even safer. So we can check off in terms of safety. The second question a lot of people have is, well, what's the best kind? Is it the compounded? Is it the bioidentical? What the heck is bioidentical mean? So the best kind of hormone therapy really is FDA approved hormone therapy. That means you can get it at CVS or Walgreens, and actually that is the most well-studied, that's really the gold standard of care, is actually to take commercially available FDA approved hormone therapy. Bioidentical simply means that it's plant-based, so they make tons of FDA approved bioidentical hormone therapy. So they make these in lots of different forms, oral, but a lot of people like transdermal. So there's patches, there's gels, there's rings. The next thing to think about is, well, we've been talking about estrogen and progesterone and testosterone. So, oh my. So, what I like to do in my clinic is help patients figure out what is the right kind of dosage. And I like to actually start with one hormone at a time, something I kind of call hormone stacking. Because a lot of the time, and I used to do this in my younger days, we'd start patients, women, on hormone therapy, maybe an estrogen and a progesterone, or an estrogen, progesterone, and testosterone, and then come back with some side effects. Or you've got that friend, it's like, I did hormone therapy, it was a mess. And actually, it's probably that they just reacted poorly to one of those hormones, not both, or not all three. So usually I like to help my patients, and this is something I do at my practice, where we start patients on one hormone at a time. It could be typically an estrogen, sometimes it's the progesterone, and it depends on those symptoms. So we talked about progesterone can decline, and that can cause anxiety or insomnia. Sometimes when estrogen's dropping, that can cause the brain fog, the irritability, the dryness, the dry skin, the hot flashes. So we start with whatever your main symptom is, and we can start adding on a hormone like an estrogen. And then when you come back, we see how you're doing, we adjust it, we find the right dose, and then maybe we add also the next in the series. If you're a postmenopausal woman and you're on estrogen and you have a uterus, it's important that you also take a progesterone with your estrogen. So those two go together oftentimes. And then the big whammy, or the big black box, is what about testosterone? And testosterone is actually a very interesting hormone to prescribe. As a prescriber, a lot of women do well with a little bit of testosterone if they choose. It's helpful for things like libido, sometimes energy, fatigue, brain fog, although there is not enough studies on testosterone because the NIH is not doling out money to look at the use of testosterone in postmenopausal women for their myriad of symptoms. Unfortunately, maybe that will change. So that is some of the main things about hormone therapy. It is safe. There's many safe ways to do it. There's different types and formulations, but what you're really looking for is an FDA-approved hormone therapy. Bioidentical is available in FDA-approved forms, and that's simply called estradiol and prometrium, although there's lots of FDA-approved forms. It doesn't have to be bioidentical. And then when you're on estrogen, if you have a uterus and you're in menopause, we want to add a progesterone and then testosterone. We can do these in all different sorts of ways. I have like a few patients here, and I always say, even though the way I think about this is like, you know how there's like 9 numbers, 1 through 9, and you can make infinite numbers of telephone numbers. I always thought that was like a fascinating fact. I feel like the same way with hormone therapy. There's not a bajillion different forms of hormone therapy, but all the different combinations and the doses, the formulations really can make for such a expansive array of options, and really it's so individualized. So just like you were saying, it's really hard to be prescriptive. One size doesn't fit all when it comes to nutrition, when it comes to hormone therapy, certainly. There's lots of myths about hormone therapy usage. When can you use it? Are you too young? Are you too old? I mean, the questions are endless. But really a lot of this is still based in sort of this fear that there's so many rigid rules about hormone therapy. You know, I have plenty of patients who start in perimenopause, and that's such a big part of what I'm going to write my book about, is that you can start hormone therapy if you're in perimenopause. This myth exists that, you know, patients will message me or people will DM me saying, my doctor won't give it to me because I have to be in menopause. He won't give it to me until it's been 1 year of no period. This is crazy. So I have a lot of experience helping women in perimenopause start on hormone therapy. Now, lastly, before I kind of give it back to you to kind of ask me maybe if there's questions about hormone therapy specifically, it's also really important to say that there's no one size that fits all when it comes to hormone therapy. And also, it's not that there's one right way to do your perimenopause or menopause journey. And I talk a lot about hormone therapy mostly because there's lots of myths and misconceptions. And I think a lot of women really are good candidates. And a trial of hormone therapy can really open your eyes as to what might be causing your symptoms and what treatment options you have. But there is, you know, if anyone says you have to be on hormone therapy or you shouldn't take hormone therapy, this sort of dichotomy is really something that needs to be squashed. And that's really important for me to kind of say as I'm talking about hormone therapy.
Yes, thank you. So one last question for all three of you, and then we'll kind of open it up to you guys to ask all the things that you want to know is, what are some of the best resources that you found for people to go to for your specific area of expertise that you would say you should know, and this is where you should check first?
Oh yeah, my stuff. No, I'm just kidding. Yes. So Menopause, the Menopause Society's website is menopause.org, and they are the leading professional organization around all things midlife and menopause. So every year they hold a big conference, and it's really fun when I'm on my way there and everyone's like, where are you going? And I'm like, a conference of menopause doctors. You know, and it's grown over the years. This is really, really exciting news. There used to be, I think, like 1,500 of us. That was it, who really specialized in midlife and menopause and took extra classes and certifications. And now it's grown. I mean, there's still only maybe 3,000, which is not enough because the math is actually really scary. But the Menopause Society is the best resource. So that's menopause.org. Another great society is also ISHWISH. This is the International Society for the Study of Women's Sexual Health. I know tonight isn't so much about sex, but this is something that's such a huge topic, and they're another great professional organization. The Endocrine Society is also great, and I also teach clinicians, and I have a director of clinicians who've taken my courses, so they really understand how to take a modern, evidence-based approach to FDA-approved hormone therapy, and that's the HeatherHirschDirectory.com. And those are some of the top resources I would think about when it comes to menopause.
A dietitian is trained in clinical nutrition to understand what happens from the minute something enters your mouth and to how you poop it out. Like, we know, and we are trained in it. I think it's important that all of you realize that now, because of women's health and the moving forward and the modernization of just women advocating for themselves, if you have insurance, your insurance probably covers nutrition counseling sessions. So whether it's a deep, dark question you might have or just figuring out ways to optimize your health, you guys are your own, you are the top resource for yourself to advocate for yourself, figure it out if you have your insurance benefits, and tap into it. You're already paying for it. Why not make it worth your time? So if it's not me, find a dietitian that works for you, that accepts insurance, but definitely seek one out to really understand what foods make sense for you, as I said, because it's a formula. Finding out the timings that are best for you, what types of foods you're supposed to eat. Some people can't have rice. Some people need to be gluten-free. Some people need to be gluten-free only at dinner. Some people can't have cow's milk, but can have sheep's milk and goat's milk. So it's very interesting, and we can play around with all of that. So that would be my PSA for this.
Truthfully, I think that skincare, menopausal skincare, is really in its infancy. I don't think there's many courses at all out there. Nobody's really talking about it. However, you treat menopausal skincare by looking after the skin's barrier, and there's a lot of research out there. So specifically corneotherapy, so that's CORNEO therapy. Any esthetician who, you know, is knowledgeable in corneotherapy will be able to treat dryness and really work towards repairing the skin's barrier, which no matter what your, you know, symptoms are, that really is the root cause of everything, is having an optimal skin barrier. And then I'm not a nutritionist or a dietitian, but I will say that what goes on in the gut is reflected in the face. So it's really important to be watching your diet. Sugar can play a huge role in glycation of the skin, which is like, it appears as a crosshatch and sagging generally in this area. And just in general, a healthy lifestyle and a really good home care routine that you're consistently using, because consistency is everything. Doesn't have to be super expensive products, but it needs to be, you need to look at the ingredients in your skincare, making sure that you're ticking all the boxes for nourishing the skin, for supporting barrier repair, for hydrating the skin cells, because they can't do it by themselves when the hormones are disrupted. And glycation, nutrition. Am I missing anything? Just, you know, and go easy with the tretinoin and all of those, like, you know, prescribed skincare products, those exfoliants, you know, once a week max is totally fine. But anything after that, you see, you know, the thinness starting to appear on your forehead, you know, you've gone too far. So you need to pull back and start nourishing the skin again. Anything else?
No, I think we're good, but questions?
So I asked 3 different doctors about HRT, and all 3 of them warned me that it would be like breast cancer, increased risk of stroke. So I would like to ask more about why other doctors are saying it is dangerous.
Yeah, this is a great question. It goes back to, this goes all the way back to the early 2000s. The early 2000s, a study came out, and it was the Women's Health Initiative. And the Women's Health Initiative was actually a pivotal moment in our lives, whether we know it or not, because before this day, really hormone therapy was prescribed all the time. And at one point in the 90s, in the early, before the Women's Health Study came out, which was 2002, at one point about 50, 60, maybe even 70% of women were taking hormone therapy. So what they found was that women were doing really well on hormone therapy. They were living longer, and there was no worry about breast cancer. But what they decided was to do a randomized controlled trial. This is the gold standard of care. So, okay, what we're gonna do is we're gonna put people in this arm, we're gonna give them a placebo, and in this arm, we're gonna give them the treatment, and we're gonna blind the doctors, and we're gonna actually, what they wanted to look at was, is estrogen good for primary prevention of heart disease? Because in the 90s, when 70% of women, that might be a little high, but let's just say 60% of women were on hormone therapy, again, they were having really good outcomes. In fact, in 1992, the American College of Physicians advocated strongly for the use of hormone therapy. Now, I wasn't there because I was like 10 years old at the time, but anyways, so the pendulum really swung when the study ended. And what was really important to know in this study that your doctors are citing is that they used a medication called Premarin or Prempro. Premarin if you didn't have a uterus, and Prempro if you did have a uterus. This is a oral combination of conjugated equine estrogen and a synthetic progesterone called majoxyprogesterone acetate. All of this lingo is actually really important because we use different formulations of hormone therapy today most commonly. So I mentioned kind of that bioidentical, patch, or you may have heard someone talk about that. And that's really important because they're not considering that there's different formulations oftentimes used now in 2025. So in this study, which started in the late 1996, 1997, they were using Premarin and Prempro. They used a wide range of women. So women on average were between age 50, or actually the average age of the woman in the study was 63, but women were between 50 and 79. Only about 10% of women, a very small percent of women were within 5 years of menopause. And then the majority of women were really at 62, 63. And then there were some women who were in their 70s, so 70 to 79. And they lumped all these women together. What they found is that in the estrogen plus progesterone arm, not the estrogen only arm, this is really important. In the estrogen and progesterone arm, there was a slight increased risk of invasive breast cancer and across their safety threshold, so they stopped the study. They held a big media conference. Again, this was in 2002, so I was watching Syracuse win the NCAA basketball championships. But anyways, so this media frenzy really came out that hormone therapy increased the risk of breast cancer. And in the study or in the media, they reported a 25% increased risk. So we're like, well, 1 in 4 women got breast cancer. And so actually, in absolute risk, this was 2 to 4 women out of 1,000 women over 5 years who were on the oral Prempro, the medications that we don't use now. So think about that again. In this study, 4 women out of 1,000 women over 5 years on oral Prempro got breast cancer. They didn't die from it, they just were diagnosed with it. This old idea exists that because they got Prempro or because they were on hormone therapy, that gave them breast cancer. We know that that's probably not true. Breast cancer is very, very slowly growing. Now, if there are estrogen receptors on that tumor, it might show up faster. And actually what they found is that those women who did get the breast cancer in that WHI outlived the women who got breast cancer in the placebo arm. Now, the interesting thing is that the women in the estrogen-only arm, they didn't have a uterus, so they didn't need to take progesterone. They had statistically significant reductions in breast cancer. They actually were protected. So the thought kind of occurred that it's not the estrogen, maybe it was that progesterone component because it wasn't in the women on estrogen only. So now when we use different formulations of progesterone like Prometrium with a transdermal estradiol, we do not see any change in the risk of breast cancer compared to your risk, whatever it is right now. And your risk might be different than your risk, might be different than your risk. And the risk of breast cancer is 1 in 8 in the general population. And it's kind of not stacked against us. And age is actually the biggest risk factor. And other things like diet and genetics. So many things I want to say there. The first is that the increased reported outcome in breast cancer was actually very small. It was massively overestimated, number 1. Number 2, it was on that oral Prempro. So now when we use different formulations, so often at my telemedicine practice, we use Prometrium, we use transdermal estradiol. The formulation's very important. The second thing, or the third thing, is that women didn't die more from breast cancer. In fact, they actually they outlived women who got breast cancer in the placebo arm. If we think about it, if they say, hormone therapy is going to increase your risk of breast cancer, the interesting thing now is that about 5% of women are on hormone therapy. So if you think now, 5% of women are on hormone therapy compared to the 90s when 70% of women were on hormone therapy, well, we must be really decreasing our breast cancer risk. No, our breast cancer risk's only gone up because there's been increased better tools for diagnosis, genetic testing, etc. Most women who are diagnosed with breast cancer are not on hormone therapy. So there's many, many reasons. I know that's probably TMI or more that you wanted to know, but it really, when you break it down, it has a lot to do with the formulation that was used. It has to deal with the fact that it was Prempro, which is a synthetic estrogen and a synthetic progesterone, and it was oral. There was 4 women out of 1,000 over 5 years. That actually sounds very close to baseline, which it probably is. And actually that the hormone therapy didn't actually cause the breast cancer. It just probably caused it to show up faster. So there's many reasons why we can debunk the fact that hormone therapy increases the risk of breast cancer.
Sure.
Okay, so what about heart attacks and strokes? That one's actually a little bit less nuanced to answer. And they really saw that in the older group of women on hormone therapy. Because when that study first came out in 2002, 2004, they lumped all these women together who were between 50 and 79. It wasn't until many years later, 2007, then 2013, and then 17, and then 20, where they looked at the age since menopause. And this is where we hear a lot about the timing hypothesis, or you have this window where you have to start hormone therapy within the first 10 years from your period. We see that the closer you are to the age of your last period, and ideally within 10 years, that this actually decreases the risk of heart attacks and strokes. And that is actually seen in many, many studies. So the age at which you are matters. The problem is you're sitting here and you're like, well, why the heck do you know this? But my doctor, who I really trust and I really love and helped me through this and that, like, why don't they know this? Why aren't you guys reading the same textbook? Well, there is no textbook either. But a lot of us, if we were trained, depends what time you were trained, but if you were trained, and when I was in medical school, I was in medical school in 2006, the one thing we learned about menopause, we were like, menopause is when your periods end and hormone therapy is super, super bad, never touch it. That was really our entire lesson. And when I went through all of my training in GYN and then internal medicine, I never saw one of my attendings who I was watching talk to any of their patients about hormone therapy because it just ceased to exist. No one really talked to women about it anymore. So you have now we're going on 3 generations of doctors who have never, ever heard a teacher of theirs talk about hormone therapy in a way that makes them feel confident prescribing it. And then there's not a lot of what's the word I want to say? I'm having brain fog now. Motivation to relearn menopause because just the way medicine is practiced. I'm going to come out and say kind of the like blunt thing, like menopause, especially in an insurance model, is not a very like lucrative. In fact, if anything, is actually a draining thing because it's a lot of talking and clinicians don't get necessarily paid to talk. So there's less motivation, although with all of this buzz and all the things that we're doing together, there's becoming more and more excitement about relearning this. So, doctors haven't had any education since like 2002. So we're going on to 22, 23 years. And then for those docs who prescribed hormone therapy, before the WHI, I know many of them as friends, they said really it just became like kryptonite and we all just kind of stopped touching it and we all just kind of stopped talking about it. So a lot of it really is, while we could say, why we could kind of be frustrated with our doctors, I really think it's the medical education system that really needs to change, prioritize women's health, right? So I think that's the reason why. It's a long-winded answer. And I'm very dedicated to teaching clinicians. It's something that I absolutely love to do. And once clinicians relearn this information with this sightline, they're like, wow, this is wild. I actually think this is actually so contradictory to what I was told before. So I have lots of resources too, because I know this could be a lot of information, and it really is. But there is a lot of, a lot of resources I'd love to help point you to so that you can have a good conversation with your doctor, or you can have a second opinion with someone else. And along the way, like teach your doctor, because each of your doctors has the ability to impact thousands of women because they're going to see thousands of women. So keep on nudging them to maybe get some re-education or say I just don't think that's the data these days, Dr. Smith, and see what we can get from there.
And I would personally like to thank you for educating these doctors. It's been very helpful.
Your full-blown menopause, is there a window where HRT is appropriate, or is there actually a window where it's just you've missed the boat?
I get this question a lot these days. And the reason is because actually a lot of the women in their 60s are like, what the hell? Why wasn't TikTok around when I went through menopause? That really would have helped me. So I get this question a lot. And it's actually probably more nuanced than just kind of like yes or no or black and white. I don't know why you're laughing. Was it the TikTok thing? Yeah. Yes.
That's like when I was 60.
Yes. Oh, okay. Well, it's exactly, but 60 is is what, I hear this myth, I'm 60, so I'm outside the window. But so let's break this down because it's a great question. So because of that WHI study, once they looked at how they prescribed hormone therapy by age, remember on Prempro or Premarin, and that's really important because one of the very first things we learned in medical school is you cannot really extrapolate from one study, different formulations or even different doses of medication. So it's important to know that study was done on oral Premarin, which there are better formulations. Now, when they looked at that, what they actually found is that the long-term health benefit, so things like less heart disease, less diabetes, longevity, There's more data for that if you started within 10 years of your last period. Now, your last period could have been 54. And so you're like, well, 60, I got you. Like I'm right in that 10 years. Or it could have been 47. So you're thinking, well, great. Now actually I've added more years to it. However, I like to say that, because now there's different formulations, there's transdermal options. If it really has been, so I always go by, first, let me back up. I always go by the 10 years instead of just the age of 60, because I have patients that have gone through menopause at 34, 24, 54. I have patients who are like 58 and they're like, you've got to be kidding me. So there's a wide range of age, and age is really more important. And some women don't know their last period because either you forgot or you had a hysterectomy or you have an IUD, so you might not know. So within 10 years from your last period is optimal really for long-term health. In that study, what they found is that if you're within 10 years of menopause, you actually had reductions in cardiovascular disease. If you were between 10 and 20 years, you actually kind of had null effect on cardiovascular disease. It didn't increase the risk. But if you were 2 decades out, if you were 70 to 79, that's when it started to increase the risk, potentially because estrogen is pro-inflammatory if it's been 2 decades, but anti-inflammatory if it's been less than a decade. And so let's say, I'm going to make up a scenario. I've had many patients come to me and work with us who are 12 years out of menopause. Everyone has said to them no, and that's not at all true. It really is individualized. So we like to look at your medical history. Do you have any existing cardiovascular disease, any cholesterol? What are your main symptoms? What have you tried? How much is it affecting your quality of life? Because there's probably not a woman on the planet I would not prescribe hormone therapy to. And again, I've been doing this for a long time. I know how safe it is and how impactful it can be, because quality of life really freaking matters at the end of the day. Safety matters too. But, a good conversation's going to help us decide. Like, women are not these docile little things that don't have autonomy over their bodies. They should have complete autonomy and have all the information in front of them. Yes. And have all the information in front of them to make the best decision. So it's never black and white. And so, for my patients who are 12 years or 13 years or 16 years out of menopause, depending on, again, their history and their symptoms, we might start a low-dose transdermal patch. And then again, some of that micronized natural progesterone or prometrium, those different formulations, of which we don't have the same data that we do from the Women's Health Initiative. We kind of extrapolate, but again, it's a different medication. So I hope I answered the question. It's never too late, in my opinion.
I've been on a patch for about 6 years. I've been in menopause for 10, and I was told to take the patch off because of blood clots, because my mother has blood clots. So they said, well, you've been on it, and you've been in menopause long enough that you can stop the patch. So I stopped it about 2 months ago, and a month later, the hot flashes came back. So how much longer am I going to frickin' be wearing this patch for? And when will those did the hot flashes come back because I took the patch off? Or is it, if I had never put the patch on, would I still be having the hot flash? Like, I find that all of these questions, no one can answer.
Yeah. Okay. I got you. I'm going to start with, actually, the first thing I'll say is there a time limit to hormone therapy? No. So there's no time limit to the use of hormone therapy. This is actually very old. In fact, it was in 2015. So it's 10 years old that both the Menopause Society and actually the OBGYN Society said there's no longer any time limit to hormone therapy. The reason that time limit exists, I'm glad you asked me about the WHI, is because based on their ages, they found that the risk sort of increased actually at 70, not so much at 60, but actually somewhere around 65. But that's if that's when you started hormone therapy. If you've been on hormone therapy, after about the first 6 months, if you haven't had a blood clot, the risk of blood clot goes right back down to just your baseline. And if you've been on that patch,
I have very high cholesterol, and I'm on an injectable for that and Lipitor. So I mean, like, does that affect it in any way?
No, not, it sounds like, I know, I sound like the transdermal estrogen also doesn't increase the risk of clots above baseline either. So if your body has been on this little patch for how many years? 5? Over. Your body is so used to this. In fact, research shows that you're actually at increased risk for clots like when you take it off. Just because there may be some vasomotor instability, do not get worried. You're going to be fine. And so, but to that point, the first point is without giving direct medical advice, there may not be any good reason you would just stop the patch, and you could probably restart the patch if you wanted to.
And that's it. You can take the hot.
Yeah. Yeah. But in that, there was a couple more interesting points, which is, I hear this myth a lot. Well, am I just going to suffer inevitably? So like, why bother taking hormone therapy if it's just going to delay the suffering? This is a great question, and it's another big pervasive myth. Now, you're going to be like, I don't think so, Heather, because I'm living proof that I'm still having symptoms. However, if perimenopause is to have any physiologic basis, it's kind of probably to get our brains used to different levels of these hormones. And it's not so fun, but that may be its point. And hormone therapy can really help to buffer some of these drops in hormone therapy. And so that means that then once you're on hormone therapy, are you on it forever? And the answer is, it really depends. Some women have different physiology. Some women, what I like to actually do is I never pressure my patients to come off their hormone therapy just because they had a birthday, but I never pressure them to stay on it either. Like, there's no right or wrong answer. But when my patients want to try to wean down, well, instead of just kind of ripping it off, we'll really wean down. It's more helpful to just wean down, because sometimes that just gets the receptors a little bit more acclimated to it. Yeah, you did do that. And so, then we'll wean down. And I always say one of two things will happen. Either you'll feel well and you'll feel okay, but we should still consider like vaginal estrogen. You still need vaginal estrogen. You still need to watch those bones, etc. And you might feel well. Or symptoms might come back, in which case we can either revisit our other options like non-hormonals, over-the-counter lifestyle, or you can go back into hormone therapy. And then it doesn't mean that you forever need it. You can always, again, maybe if you were, it always depends on the patient. You might be like, I really want this thing off. Like, I want to be done with this. I would say, let's give it another year or so and let's wean down again and see what happens. So it doesn't mean that you're doomed forever either. It's just, it's so interesting because we all have different receptors and they all get irritated, some more than others. And some of them are kind of quicker of like, I think the estrogen's gone, I think we should shut down. And some of them are like, no, I will stay here and fight till forever. And we don't know who has which kind. And so, some of us are just going to be, the way I kind of talk about this is between the menopause community, they'll kind of argue, is menopause a hormone deficiency syndrome or is it really natural? And I don't know if this is even worth arguing, but for some women, it really does feel more like a hormonal deficiency. And without the hormones, they really just feel crappy. It's almost like hypothyroidism. You don't have synthroid. You're not making that hormone. And so if anyone here had hypothyroidism and I just said, well, time's up for your synthroid, you just kind of have to live with it. I'm pretty sure a lot of women wouldn't feel so great without their synthroid if we just kind of took it from them. But I also have some patients that are on thyroid medication, and after some time, we kind of stop and they actually feel great. So I think there's so much that we don't know. But I want to bust a couple of myths. There's no time limit to the use of hormone therapy. You shouldn't be forced to come off it just because. Although sounds like there was some medical rationale, but I would argue you already kind of stress tested having a clot and you didn't have one, so it doesn't sound like there'd be any reason to take off the patch, which is a nice transdermal bioidentical FDA approved commercially available option. So there's no time limit to the use of hormone therapy, but if you do come off, one of two things will happen. Some women feel well, sometimes the symptoms return with a vengeance, and you can put your hormone therapy back on. And doesn't mean you're doomed forever. You could try again another 16 months or 2 years, but just don't be too I always kind of say like to my patients, like, your body will tell us what you need. And that's just kind of usually my North Star.
Hi. So my question is about, once you put a patient on the hormone replacement, your testing methods, and then what is the magic number? Is it very individualized to that person? And then when you're on it, do you adjust a lot, or once you have that formula, it stays that way? So it sounds like you're going to be on for years. So sort of that's your dosage, so to speak, and you stay with that dosage. I guess that's my question.
Yeah, this is a question that's been asked a lot lately, is basically, how do you know when your hormone therapy is right? And how do you know when to make adjustments and what are the right levels? And again, it's individualized, but let me do my best at sort of thinking through how can we generalize this to make some sort of sense of something. So I have this motto when I think about hormone therapy. I always think to myself, I want my patients to feel 70 to 80% better at minimum. If we get you to feeling 95% better, it's probably not just the hormone therapy. It's just that life is great. But 70 to 80% better with limited side effects or no side effects. And for most of my patients, that tends to fall in an estrogen level, if we're going to check in the blood, somewhere between 40 and 70, sometimes less, sometimes a little bit more. There's no hard and fast rule, and I usually don't use labs necessarily to guide me. I really use what my patients are saying. So I'm looking for the hot flashes are mostly gone, I'm sleeping again, I'm not having any bleeding or breast tenderness. Got it. That's how I know you're probably in the right zone. It's doing its job and you're feeling good. The other thing I think about is it has to fit into your lifestyle. So some women are given the patch, but they like forget to change it. You know, it's like, oh gosh, day 4, like, oh my gosh. Or they're given the gel, but like their dog's coming up and licking them, so they never put it on anymore. Like, there's so many fun stories I get to hear. Or their kids are pawing at their patch. Like there's just so many funny things that happen. So it has to fit into your lifestyle, has to make sense for you. And you have to feel really confident about it, because I always say, the biggest risks of hormone therapy are not the scary things like breast cancer and starts. It's actually probably bleeding, breast tenderness, and then your mom telling me that I'm trying to kill you. And so as long as you feel confident about your HRT, it fits into your lifestyle, and you feel really well on it, you're going to do great. And so we make adjustments, or I like to make adjustments to my patients every 6 to 8 to 10 weeks until they start to feel really good. And so a lot of times once we find your right dosage, we can kind of sail like that for a while. But interestingly, a lot of my patients are finding sometimes things need to be tweaked and changed. We're using different hormones now, like a lot of GLP-1s, and GLP-1s, which are another hormone, might mean we need a little bit of a tweak in our hormone therapy. Some of my patients have different homes, like across the world, and when they travel, they sometimes need different dosage, which is wild and interesting about our physiology. So sometimes they have a dose they use when they live in Cambodia, and sometimes they have a dose they use when they live in the States. It's so interesting to me. But what's really nice, and what we love to do with our patients, is really kind of find I'd call like a base formula for you. What's the formulation or the routes of the hormone therapy that you like? And then my patients kind of almost start to learn. They're like, I think it's too low. I think it's too high. And, we kind of can make little tweaks over time. But oftentimes the biggest challenge is that first, probably 6 months or so, it can take a little bit of time to kind of find the right, I always call it Rubik's Cube, like find the right couple of clicks, and then you've really found something that you like, and then we make adjustments from there.
Okay, I think we have time for one more. Okay.
Thank you, and thanks for the accessible, intelligent, open conversation. I'm part of the 5%. I started HRT 6 weeks ago, I think yesterday. Really having a great experience. My question is, I'm on 50-50 estrogen, progesterone, a cream, and then I'm on DHEA. I don't think I quite understand DHEA. Could you speak to what the potential benefits of taking that are? And I'm on that orally.
Yeah. So great. So DHEA is a androgen precursor. And so it's also available over the counter. So if we all went to Whole Foods, we might find DHEA, although oral. So DHEA is a over-the-counter precursor to our androgen production line, which includes our friend testosterone. And testosterone, I think I mentioned at the beginning, when we're kind of thinking about the trifecta of hormone therapy, there's your estrogen, your progesterone, and then your testosterone. I have an ice cream cone theory about hormone therapy, which I will tell you because it might help. I think about hormone therapy like if you're craving an ice cream. For us in upstate New York, it's Abbott's, but wherever you like to go, estrogen is like the ice cream. It's like the main ingredient. You really wanted ice cream. You wanted something cold and creamy. That's like your estrogen. That's going to really help with the majority of your symptoms and your long-term benefits. Progesterone is kind of like the cone. It's like a little sugary. Sometimes it's great. Sometimes you want it. Sometimes you need it in a dish if you've had a hysterectomy. So progesterone's like the cone. And then the testosterone's like the sprinkles on top. It's kind of like the toppings that you like to put on it. Meaning, really, me personally, just kind of treating so many women, I find it sometimes nice to just get your estrogen right, your progesterone right, and then add some of the androgens in. So DHEA is actually just a precursor hormone that's not like as strong as just giving you testosterone. So DHEA, in my opinion, is often sometimes used as this intermediary of like, let's see if this works to give you a little bit of that androgenic effect, which could be muscle mass or libido or brain fog. And again, I think I mentioned before, we need so much more research on low physiologic doses of testosterone in women. So you're kind of like, I'm still not sure. Yeah. So if you don't feel like it's doing anything, you know, again, while I'm a doctor but not yours, you might want to try it with and without it. And if it's not really doing anything, but you still feel like maybe you're having those symptoms of low testosterone or your testosterone's low in your labs, you're curious about testosterone, I kind of say the DHEA doesn't really do terribly much in a lot of my patients except for placebo, which is actually very strong, and that you could just go right to adding testosterone or androgens if you feel like the DHEA is doing nothing. So I would kind of test it, like use it for 2 weeks without, is it in the same cream or it's probably separate?
Separate.
Yeah.
DHEA is oral and
Yeah.
the estrogen, progesterone is 50-50 in the cream.
Yeah.
So I would have to either stop it and do my own like
Yeah.
little like semi-controlled experiment.
Definitely got it.
But
Yeah.
I'm like kind of afraid to stop it because I was told to take them both together.
I know. So this exactly, and this is kind of why I like to stack them. So don't be afraid, even though, but you know what I would say is like, wait 3 months and then drop it and see if you notice any difference. Give yourself that win of like, okay, I feel better. I'm feeling steady. Now let's kind of like let's really refine this. So let's drop the DHEA and see if anything happens. And my guess is you're going to continue to feel great.
Thank you guys for coming. This is great.
I have one
You
question.
have a question?
Yes, Heather, just because I hear it a lot from my clients too, can you speak to the mood swings, the feelings of craziness? What else? The mental side effects, the husbands, the poor men that are, I hear it a lot in the treatment room and it's not really been mentioned, so figure.
You are on the front lines of hearing about all of this, and it's a big reason that I think the allied healthcare professionals are such an important part of just the menopause conversation. Okay, so short fusitis is what I call this, and I've experienced it myself. Oh, you're gonna take me talking about it? Yeah, okay. And it's like, so a couple, you know, it's, first things first, of course, menopause and hormonal changes like don't happen in a silo. We are the most busiest, and you know, our lives are really very fast paced right when our physiology changes yet again. So it's never just one thing. But estrogen can be an antidepressant. Estrogen actually increases serotonin in the brain. So it's like a natural serotonin reuptake inhibitor. So estrogen may help us feel happy. And as estrogen drops, we can sometimes feel low mood or irritable, especially if it's changing really fast, which is more common in perimenopause. And then in menopause, when the estrogen's low, that can sometimes feel more like anhedonia or even depression. And even Oprah said that. She said the sky just wasn't blue anymore and I had everything in my life that I ever wanted, which makes you feel more depressed. Progesterone can make you feel a little bit calm. So as progesterone is declining, that can also be that anxiety. And so you've got this storm of like, you know, low progesterone and maybe low estrogen. So in perimenopause, you can feel sometimes more anxious. You can feel that short fuse where you just like, all of a sudden you feel like something has just entered into your body, and the fire you are breathing, like you're watching from above, right? I don't know if anyone's had that experience, but please tell me you have, because I certainly have. Yes. You just are snapping it like your kids, your partner, your coworkers, people on the street, whatever it might be. And you're like, that just doesn't feel like me. That happens all the time. And I think it's because, again, of those drops in our hormones. And then postmenopausally, with that low estrogen, that can sometimes move into more like depression or anhedonia or lack of joy. I had a patient tell me she loved to decorate for the holidays. And for the last like 2-3 years, she just had no joy. She's like, I don't want to take anything out. I don't want to decorate. I just, no joy. And we started her on hormone therapy. And again, not that this is just the only factor. There's so many things involved. There's the support of your family and your friends and your environment and etc. But, she came back and I was like, are you decorating? She's like, funny you should ask. I am decorating. And it's just one of those little stories that reminds me that the hormones play a big role in our brains, in our moods. And again, this is why I just think not only is this fascinating, there's so much more research that needs to be done. And there's a lot of different ways that we can help ourselves through this transition. Great question.
Thank you.